Now, what happens when you tear your ACL and you release those chemicals into the joint, or you bleed into the joint, is the synovium becomes activated, okay? And it becomes synovitic, so it's inflamed, essentially. So when synovial tissue is activated, it moves from about 3 cells thick to about 10 cells thick. And what this does is it contributes to the intra-articular swelling of the knee. So you've got blood going into the knee, but you've also got, instead of 3 cells generating fluid, you've got 10 cells thickness generating fluid. So you get intra-articular swelling. But what also happens is it becomes more leaky, so it allows more white cells and more proteins, things like platelets, into the joint. And the principal idea for that is to firstly stem the bleeding. You don't want your ACL bleeding into your knee for 6 months, but it also starts the repair process. And inflammation goes through quite a nice process that is well timed, lasting approximately 12 weeks. So firstly, it'll stop the bleeding, then we go into a remodeling process where we start to heal any injuries within the joint. And anybody that's seen an ACL tear knows that you aren't going to see inflammation at 6 months, for example. So that's a normal process. And once that healing situation is resolving, the synovium is not triggered anymore by the proteins or the broken chemicals. It's not triggered anymore, so it settles down and the whole thing goes back to normal. Now, in rheumatoid arthritis, what happens is your immune system becomes blinded to the synovial tissue. So it thinks it isn't you anymore. It thinks it's a bacteria or a virus or a splinter or some sort of invasive whatever that's got into your body, and it starts to react against it. So what you do is you generate antibodies. So imagine your immune system thinks that your synovial tissue is a virus or a bacteria. It starts to create antibodies against your own tissue. So these are auto-antibodies, so antibodies directed against the self. And what happens is that activates the synovium. The synovium goes from 3 cells thick to about 10 cells thick. It starts to generate more joint fluid and it becomes more leaky to platelets, white cells, so on and so forth that we've already talked about. So those go into the joint, but this time there's nothing for them to heal, there's nothing for them to remodel. So they just sort of float around within the joint and eventually they start to just damage healthy tissue. And you get characteristic erosions of the joint. The other problem we have here is because there's no injury to resolve, the synovitis never settles down. So the immune system just continues activating the synovium. Now what's really interesting again about synovium is that it also activates the inflammatory system. So imagine when you injure your knee, what happens is you get that synovitis, but you need an increased blood flow to the area. You need those white cells to be brought to the area so they can get into the knee. Now, that same thing is happening with rheumatoid arthritis. So what happens is the immune system activates the synovium, which activates the immune system, which activates the synovium, and you get into what's called a chronic inflammatory cycle. So you just go round and round and round and round, and things deteriorate. So you follow this fairly obvious process with rheumatoid arthritis where it will start, and we typically will say you get subclinical rheumatoid arthritis. You've got inflammation occurring but no symptoms. You then move into a clinical phase, and what that tends to happen is you get some mild symptoms which then deteriorate. So you get more symptoms within each joint, but you get more joints being affected as the antibodies that are generated start to affect not only one joint but multiple joints. And then you get into a chronic phase, which never settles. And this is why we need medication currently to interrupt that process. So it's really, really problematic. And unfortunately for us as physiotherapists or musculoskeletal therapists, there's very, very little we can do about that. We need rheumatologists to intervene with those medications. So we can also talk about spondyloarthritis here, and the same process, pretty much exactly the same process occurs, but this time at the enthesis of joints and the spine. So where you've got high-load tendons or high-load ligaments, as they blend into bone, that's where this inflammatory process is occurring. Again, you become blinded to that area of the musculoskeletal system. It generates inflammation and you get symptoms. You get slightly different distribution because it's ligaments and tendons rather than synovial joints. So typically with rheumatoid arthritis, we're going to see the MCP joints affected, and you can imagine that you've got multiple joints very, very close to each other. So it's easy for the antibodies to move from one joint to another. And then with spondyloarthritis, as we've talked about, you're typically going to get the spinal ligaments, the sacroiliac joint ligaments, and the high load peripheral ligaments affected, just because they are the ones which are taking the most load and they have a slightly higher resting level of inflammation anyway because of that. So that's where those sort of things start to begin.